Uh, so, just to brief everyone, myself and Dr. Kamlesh, madam has already introduced me. I'll just put the screen on the slideshow mode. Uh, just a minute. Today what I will try to do is it is acyanotic heart disease, the topic which is given to me today. So we will try to cover ASD and sorry, unable to 1 minute. Yeah. So it's a full screen, is it? Uh,
Yeah, now it's a full screen.
So today we're going to cover ASD and VSD, and if time permits, then we'll cover also the PDA. Otherwise, we will cover the PDA tomorrow with tetralogy of Fallot's. These are four basic congenital heart disease which we are going to discuss. I have tried to keep myself very basic, but because I want to give some extra knowledge to the students if they are want to be good at it, so I included slightly detail in the topic. So please excuse me if I'm going slightly higher than what you may needed it, but I think you will be kind of going to enjoy the topic of both the ASD and VSD. So starting with the ASD. So before starting this ASD, VSD, or tetralogy, we'll classify the congenital heart disease. It is broadly classified into acyanotic and cyanotic, which is a topic heading of today and tomorrow. The acyanotic is been further classified into left to right shunt. So we are talking about today the atrial septal defects as well as ventricular septal defect. Both are left to right shunt. And if time permits, we are going to talk about PD also. In the acyanotic, there is outflow obstruction disease also come under this heading. So either it is pulmonary valve related problem or aortic valve related problem. So AS or PS or severe coarctation, both fall in acyanotic category. And cyanotic category, it is tetralogy of Fallot's and TGA. But if you want to classify further into further detail, I will try to include this busy kind of a flow chart where just to add on the cyanotic, you can have all TTT. So it is TGA, TAPVCs, truncus arteriosus, tetralogy of Fallot's, and tricuspid atresia. If somebody can remember all these things, it is very easy to remember cyanotic heart disease for the congenital heart disease classification. We're discussing today is atrial septal defects, and honestly, it is looking very simple for the surgery anesthesiologist and to learn this topic. But because it is simple, nobody wants to make a mistake in that, either for the surgery or it comes to your viva also. It is difficult to make a mistake, or somebody is making mistake, it will not be pardonable. That is why one has to know this thoroughly. So either it is, if somebody is conducting this case for the surgery or anesthesiologist, sometimes it is horribly simple, but sometimes it's simply horrible. And if that goes reversed, I think you will have a nightmare of what we had. First case of Kokilaben Ambani hospital, where we put a ECMO in the case of ASD closure. So this patient was extubated, and midnight the child is arrested and put on ECMO. And then later on, after 20 days, we able to discharge this patient. So it is not the thing that all the ASD case will be very easy to handle. And as I mentioned here in the slide, that mortality in ASD will not be pardonable. But if you are having a mortality of very complex congenital disease, it's okay. That because there is already the higher mortality rate all over the world. So that is why it is sometimes it is not given to the junior most person, or even the anesthesiologist also. One has to be very careful by managing such simple defects. ASD is one of the most common acyanotic congenital heart disease, and because the left atrial pressure is higher than the right atrial pressure, the shunt is from the left to right. It occurs in 1 in 1500 live births, or comprise 6% to 10% of all congenital heart disease. It may be a small to large depending on the size of ASD, and then later on, because of this size of the ASD, there will be a lot of pathophysiological changes also. So if you want to classify anatomically, it is mainly classified into 4, but I will describe 5th and 6th also here. Starting with the first, it is patent foramen oval. It is in a short form easily called as PFO. So PFO is small interarterial communication. When there is no deficiency in the septum, it is necessary even in the fetal heart life to be there as a PFO. Otherwise, it will be very difficult the child to survive even in a fetal heart life, which we'll discuss in some of the other slides today or tomorrow. So PFO is normal communications in a fetal heart life, and because gradually after birth the LA pressure rises, it closes. So functional closure of PFO happens immediately after birth, but sometimes anatomical closure can go up to 6 to 10 weeks. But in some of the cases, it remain open even in adulthood, and sometimes it is diagnosed accidentally that there is a PFO in normal human being also. So the prevalence is around 27%, and it is very critical to be present of PFO in a cases where TGA, pulmonary atresia, tricuspid atresia, hypoplastic left heart syndrome, because there the atrial mixing has to happen to keep the child alive. That is why it is critical. Right to left shunt in adulthood causes paradoxical embolism and cerebrovascular accident, and that is why if it is diagnosed, sometimes it is needed to be closed, either transcatheter or sometimes surgical. The second is primum ASD. The primum ASD is a crescent-shaped defect in inferior portion of atrial septum. It is inferior portion of atrial, and then it is associated with either partial or complete AV canal defects. And this defect is caused by an defective development of endocardial cushion, and usually associated with trisomy 21. So this is how it looks in echocardiography or in diagrammatic way. Either it can be shunt from right to left, or it can be shunt left to right, depending on the pressures in RA or LA. The secondum ASD is the third type of classification of ASD. It is most common and result of deficient limbus or septum secundum, and sometimes it may be fenestrated rather than having single defects. Left to right shunting across the defect because LA pressure is higher than what I mentioned, the RA pressures. And because the left to right shunt, there is a large volume of blood from going from the left to right, RA RV dilatation may happen, sometimes hypertrophy also. And then if it is not been treated in adulthood, it may causes, because of high pulmonary blood flow, there will be vascular changes happening in the pulmonary vascular bed, and sometimes it will give problem, and then some of the cases we describe this as a Eisenmenger, because it started having a pulmonary vascular occlusive disease. Some of the cases of ostium secundum ESD is associated with mitral valve abnormalities. Either it is associated with mitral valve prolapse or mitral regurgitation. The fourth one is sinus venosus ASD. In this sinus venosus ASD, either it is SVC type because it is near SVC, or it is IVC type if it is inferior and associated near to the inferior vena cava. So it is either SVC type or IVC type. IVC type sinus venosus ASD is very rare, but we have seen many of sinus SVC type of ASD, and this is usually associated with PAPVC, which is called as partial anomalous pulmonary venous restriction. So right side upper pulmonary vein, usually in association with sinus venosus type ASD, is draining into the right side of a heart, and later on while repair, the surgeon has to repair both things. The fifth one, which I mentioned, that usually the classification is around 4 anatomical classification of ASD. The fifth one is coronary sinus ASD. Usually the coronary sinus behind the RA, behind the LA goes and then draining into the RA, which drain all the deoxygenated blood from the heart to the right atrium. But if this is been unroofed, and then it is draining into the LA, it causes desaturation, and sometime need to be closed if it is associated with persistent LSVC, and because of large amount of blood coming from there, from the LSVC to the coronary sinus and draining it to the either left side. So this complex of it is with, if it is associated with LSVC, it is called as Rakib syndrome. May not be very popular syndrome. If somebody wants not want to remember, it is fine. And usually it is associated with heterotaxy or asplenia syndrome. So these are the anatomical what we have discussed. Near the tricuspid valve, if it is defect, it is ostium primum defects. Ostium secundum is a defect where there is a defect in the ostium second for the secundum ASD. If it is near the sinus venosus ASD, it is SVC type. And because it is near to the right upper pulmonary vein, the right upper pulmonary vein also is draining into the RA. And if it is near to the inferior vena cava, it is called as IVC type. And then last what we describe is coronary sinus ASD. The sixth one, actually it is not coming under the heading of ASD, but sometimes it is just called as common atrium, where there is no septum. There is no development of septum at all, and that is called as single atrium. So which is also associated with sometimes other cardiac anomalies. So this is how there is no septum in the atrium, and it is called as common atrium. Here also in echo, you don't see any atrial septums. But this is not routinely come in the classification of ASD, but just to complete the defect of interatrial septum, we are included here as one of the classifications. Coming to the embryology of atrial septum, it started with the 5th or 6th week of gestations, and then it started with the septum primum. Septum primum start growing downwards towards the already fused and developed endocardial cushion or secondary septum. And then there is a defect here, which is normally should be there when the fetus is developing. And this defect is called as ostium primum defects. And here during the fetal circulation, the right side of a blood going to the left side, and there will be a communication. So this is normal, and gradually the endocardial cushions gradually develop, and then it form full septum. But then there will be a fenestration start happening in the upper part of a septum primum. Initially, it will be a fenestrated holes, and then it become a big hole, which is called a septum secundum. So septum secundum is abnormal connection, but it is normal during the fetal heart life. And then after formation of septum foramen secundum, there will be a secundum septum, which is right to the septum primum, will start growing and going and kind of projecting downwards. And this will make one defect which is called as tortuous defect, which is called as patent foramen oval, which is necessary during fetal heart circulation, where the IVC blood directly divert, oxygenated blood directly divert towards the LA, which is also normal in fetal heart life. And gradually, once the child is born, this is defect has been closed. So this is how the embryologically we describe the development of atrial septum. Coming to the pathophysiology, the shunting of a blood across the defect depends on size of defect as well as the pressure between both the chamber, right and left. So obviously the left atrial pressure is higher than the right atrial pressure. There will be a right to left shunting, and the amount of shunting depend on the one is the size of a defect, second is the compliance of RA and RV. So during the infancy, there will be minimal shunting because there is a high pulmonary vascular resistance, and that is why RV EDP is high, and that is why RA pressure is high, and that is why because there is much less difference between RA pressure and LA pressure, during the infancy, there will not be much shunting. And gradually the PVR decreases and the shunting increase towards the right side of a chamber, and gradually the symptoms start appearing in the age first or later on preschool age group. So this is what we already described. So there will be volume overload from of RA and RV, and gradually the RA-RV volume overload transmitted to the pulmonary vessels also, and gradually there will be a severe pH developing because there are high pulmonary blood flow going from LA, RA, RV to the pulmonary circuits. And later on, rarely this adult ASD patient also can develop Eisenmenger syndrome, where pulmonary vascular disease, pulmonary vascular resistance becomes so high that the RA blood or deoxygenated blood mixing to the left side of a chamber, the reversal of shunt will happen, and that is called as Eisenmenger syndrome. This is what we already described, left to right shunt to start with, but because of a higher RA, RV and pulmonary blood flow, there will be endothelial dysfunction and pulmonary vascular remodeling is happening During the adulthood, especially because of increased pulmonary vascular resistance, there will be reversal of shunt from the right to left, and that is called as Eisenmenger syndrome. The natural history of ASD is small defect, usually close, less than 3 mm, mostly close spontaneously, no need for any treatment. The median size defect between 3 to 8 mm. Some of the kind of defect is been closed spontaneously by the age of 5 to 6 years. Around 80% has been mentioned here. And the larger defect, which is more than 8 mm, most probably they will not close. So some of the patients, as I have mentioned, diagnosed later in adulthood because some of the median side defect has been not closed and the child will not be symptomatic. They will undiagnosed, remain undiagnosed and reach to the adulthood, and later on either accidentally or some of the physician or pediatrician can develop, can heard a murmur in the pulmonary area and then performing echo and able to diagnose that there is a defect in the atrial septum. So the symptoms regarding this is, as I mentioned, many of the ASD patients usually remain asymptomatic, or some of the cases has been diagnosed during preschool just examination, physical examination as a government or some of the trust is running such kind of a program. Echocardiographically, obviously, it has been diagnosed easily. Some of the patients come with a frequent URTI, and these are the patients, even if they're coming at 3 years or 4 years, it is one of the indication to treat the disease, or either it is closed surgically or by device. Rarely this patient of ASD comes with the congestive heart failure symptoms. Regarding the physical examination, RV and RVOT pulses are increased and hyperdynamic because there is an increased blood flow from the RV to the pulmonary circuits. There will not be thrill. There will not be audible murmur because of ASD, because hardly the flow gradient between LA pressure and RA pressure is not very high, and that is why there will be very soft kind of a murmur which will not be audible on stethoscope. So there will not be audible murmur for the ASD, but there is a ejection systolic murmur which is soft and low intensity, and it is because of increased pulmonary blood flow. And sometime you may get mid diastolic flow rumble because there are higher amount of blood going from the tricuspid valve. So it is the relative tricuspid stenosis, we can say. The term is not actually it is tricuspid stenosis, but because there is a higher flow, the normal tricuspid valve flow also giving such kind of a murmur. So these are the physical examination for the ASD patients. Coming to the evaluation of such kind of patients, if you are perform X-ray, there is a typical X-ray of ASD patient. There will be a cardiomegaly because of RA-RV dilatations. Because of RA and RV dilatation, there will be a cardiomegaly present. Prominent MPA because of high pulmonary blood flow. There will be higher or prominent knuckle of pulmonary artery area, and there will be increased bronchiovascular marking because of a higher pulmonary blood flow, and that is one of the reasons that this patient will have a URTI because of higher pulmonary blood flow. Keep on having a lung congestion, they are tend to have a high chances of infection. But later on, if this patient come with a Eisenmenger syndrome, there will be changes in the X-ray happen. So there will not be any cardiomegaly here. There will be peripheral pruning. That means the last 1/3 or 2/3 of the pulmonary lungs area will be oligamic, and there will be only prominent PA and pulmonary marking seen in only 1/3 of central area only. So that is what is one of the diagnosis of Eisenmenger syndrome associated with the clinical cyanosis as well as echocardiography. And if there is a lateral X-ray been performed, there will be RV enlargement seen on the lateral X-ray. So this is X-ray of Eisenmenger syndrome. Either it is because of ASD or sometime associated with other congenital heart disease. Regarding the ECG, because there is RA-RV dilatation and sometime RVH, you can see there is a I think changes related to the right ventricular hypertrophy. These are the these are the spike which is taller than what normal. It is suggestive of RVH, and you can see here RS pattern, which is typical of ASD. Echocardiography, I'm not going to go into much detail, but you can easily diagnose ostium secundum and ostium primum on echocardiography, either in the four-chamber view or either in the long axis view. The difficult to diagnose is sinus venosus ASD, SVC type, or IVC type. So there has to be really high index of suspicious the expert pediatric cardiologist can able to diagnose SVC and IVC type of ASD, which has been missed by many of the good cardiologists also. So we are not going to, this is ostium primum ASD. It is in the four-chamber view. And this is ostium secundum ASDs. Also, it is in one of the four-chamber views. So, and this is fenestrated ASD seen in one of the transgastric UOs. Many of the we can able to diagnose. So we are not going to detail of that. The other mode of diagnosis, which is invasive kind of evaluation, is catheterization and angiography. It is not always necessary to diagnose ASD by this method, but sometimes it has been taken for transcatheter device occlusion of ASD, and in association with the cardiologist will perform this kind of study, which is called as oximetry study. So what they will do is they will find out first how much is the step up of oxygen. Step up means because the oxygenated blood going from the LA to the RA, there is a higher saturation of RA and RV and PA compared to SVC and IVC saturation. So if that is called a step up of saturation. So this step up will be sort saying that there is a left to right mixing happening at either usually at atrial level. And then depending on the various data, they will take pulmonary venous saturations, aortic saturation, pulmonary artery saturation, and SVC or IVC saturation. They will able to calculate degree of shunting, and then they will calculate this QPQS, which is the flow of quantum of flow going from the going in the pulmonary circuit and quantum of blood flow going to the systemic circuit. If it is 1.5 to 1, that is 1.5 amount of blood is going compared to the systemic circuit. This is one of the indication to close the ASD. The pressure study, usually they will not necessary when there is a large defect, because there will be obviously the large defect equalize the pressure between RA and LA. But because of a large defect, there will be higher PA pressure. And sometime in adulthood, if a patient comes for the device closure or surgical closure, to rule out that there is reversible pulmonary vascular resistance is there, they will perform this kind of study to measure the pulmonary PAH as well as RV pressures, and then they will give oxygen, either oxygen or nitric oxide, to see that there is a reversibility of PAH, and then only they perform either ASD closure surgically or device. How to manage this kind of patient is when to go for surgery, what are the indications, and what are the management of if they are going for surgery. So when they should operate, usually they will be asymptomatic, but as I mentioned, they come with either arrhythmias, which is very late, but they usually come with a recurrent URTI. That is one of the indications to operate this kind of patients. On echo, there is a PEH is there, and significant PH, pulmonary hypertension is there. That's one of the indication to operate. RV has become enlarged, hypertrophied, dilated. There is indication to operate. Tricuspid valve is start leaking because of there is high blood flow going through the tricuspid valve, and which lead to RV dysfunction, and the tricuspid valve also start leaking. One of the indication. Timing of surgery is usually preschool, because it's open heart surgery. Better to close before school age, and then they will have their normal schooling and their normal education schedule. So that is why we need to close. If we are not closing, the exercise capacity start having reducing. There will be a lot of arrhythmias later part of a life, and that is why one of the reason to close this. There will be a chances of PAH or pulmonary hypertension. There will be chances of heart failure. So these are the reason we want to close at least not very early, but 5 to 6 year of life if it is diagnosed and having symptoms. There are two ways of managing this. One is medical management and one is either surgical or device closure. Medically, this patient can be remain in follow-up if there is asymptomatic and not much symptoms. So they will be, the cardiologist will write diuretics and then they have a follow-up of 3 months or 6 months depending on the amount of problem of the patient. So that is what I mentioned. Anticongestive measure of diuretics and digoxin will be there for this patient, and then obviously they will follow up this case, and later on, obviously, if it is needed, if not closing spontaneously, they will advise for device or surgical closure. Indication for closure is, if I mention again, this if to prevent development of pulmonary vascular obstructive disease, to reduce the arrhythmias which already have been mentioned, and to prevent severe symptoms or heart failure during adolescence. To prevent all these things, one has to close ASD. It is 4 to 5 years is recommended, or preschool age is recommended for the closure, elective closure. It will be always. Child should be symptomatic. RV volume overload will be documented on echocardiography, and QPK should be more than 1.5. Surgically, it will be a routine surgery. As I mentioned, it will be always elective surgery. So there will be a midline sternotomy under general anesthesia, and I'm not going to go into the detail of all the steps, but they will close with usually close with a pericardial patch, and then it will be routine surgery for most of the units. We will not go into the detail, but I will mention here that surgery nowadays in current era is only reserved for the ASD if there is a deficient ream and not able to close not able to perform device closure. Number one, the cardiologist intervention cardiologist is not confident or unsuccessful of closing the device. If there is a sinus venosus ASD, coronary sinus ASD, or ostium primus ASD, these are the all for the surgical closure. Nowadays, even cardiologists can close sinus venosus ASD with a different kind of a device available and associated with other intracardiac problem. These are the indication for surgery. Otherwise, nowadays, most of the ASD will go for device closure. So device closure, transcatheter closure of ASD is one of the kind of treatment of choice. And last 2 to 3 decades, most of the cardiologists are well versed of how to put a device and which device. There are a lot of device available, including implizer, and there are a lot of other names which we need not to remember. Just rule of thumb, what is been I also found from the book is it is the device can be closed, can be closed if it is not exceeding the body weight. Suppose the patient's age is 15 kg, the diameter of device is or the defect is 15 mmHg, can be closed with the device. If it is larger than that, that means the cardiologist is taking undue risk of closing this device, and better to go with a surgical closure, which is also having very or nil mortality rate nowadays. And I'm not going to go into the detail, but cardiologists will measure all the ream, and they measure the exact defect and then decide about which device to be put. They usually measure 5 ream to judge that whether this patient will go for device closure or not. Usually the aortic ream is one of the aortic ream, and IVC ream is one of the important ream for that device to be fit in that position, and that is why these 2 rings are important when the cardiologists are assessing for the device closure. And this is how the cardiologist will put a device. It will go from the IVC, the catheter will go, and then sheath and catheter. They will put the wire into the one of the left upper pulmonary vein, and then they put a sheath towards that, and then they inside the sheath there will be a device. They initially put the LA disc, and then gradually withdraw the sheath, and then the both disc will be placed, and then they will, before releasing the sheath, they will confirm it with the echocardiography, either transthoracic or usually TEE. This is how the device will be placed in the atrial septal defects. So we'll not go into the detail of all these things. The anesthesia is, which we already discussed many of the points. I will go very fast with this. history taking is important symptoms to know for the when we are going for the PACs. There will be loud P2. There will be if a presence of cyanosis, we should be alarmed when somebody is seeing with the ASD, and then it has to be discussed with the operating surgeon if there is a cyanosis associated with the ASD. ECG will be there, and then we can see the changes in the ECG. Chest X-ray we already discussed. Echocardiography, we want to know the size of the ASD and associated problems. And shunt fractions, obviously the cardiologist will not work unless they have been needed. As I mentioned, either surgical or device closure, there are two ways of doing it. And transcatheter, we already know. Only thing I want to mention about transcatheter is most of the unit perform under GA, but there are some of the unit they are performing under LMA. If a cardiologist agree to do transthoracic echocardiography, it can be performed under LMA also with sedation. But it's fine depending on the comfort of cardiologist and anesthesiologist. Otherwise, short-acting muscle relaxant and routine in midazolam, ketamine, and some of little bit of opioids can be used, and then on-table extubation in most of the cases. Either it is surgery or device closure. For the surgery, we put both artery line and center line, and it is routine for. We are using caudal block for this kind of patient because we like to extubate on table when there is a ASD. We are using dexmedetomidine infusion to reduce the pain, and multimodal analgesia like paracetamol, dexmedetomidine, and caudal block will help to extubate this kind of patients on table. Otherwise, we are using sevoflurane and then routine reversal at the end of a surgery. Monitoring, as I mentioned, and then if needed, we perform TEE to check that repair is been closed properly or not. Otherwise, choice of inotrope, usually they need not require inotrope, but most of the cases we starting dopamine just to come off, and later on in the ICU we taper off the dopamine. Only rarely we are using Melanon in such kind of patient when we are documented right ventricular dysfunction also is there. Otherwise, rarely we are using Melanon, and rarely we are using adrenaline. So early extubation arrhythmias, one has to be watchful, but usually they will not have much arrhythmias, and even low cardiac output is rare in ASD patients. The last one is sinus venosus ASD. There are different type of a repair apart from routine closure, which is we are routinely performing this when there is a sinus venosus ASD. The surgeon will close the ASD patch in a way that it will close kind of close the defect, but later on because this to prevent long-term stenosis in pulmonary vein, our surgeon used to remove this SVC and attach to the RA appendage, which is called as Warden procedure. And then it has a very good result. There is no problem with performing such kind of surgery also. Last slide is for this if a ASD patient comes for the non-cardiac surgery, if it is unrepaired ASD, then one has to go for the detailed echocardiography and find out there is a severe PH or mild to moderate PH or not. If it is moderate to severe PH, this falls in high risk category if somebody is performing non-cardiac surgery in unrepaired ASD. So that part one has to be very watchful. Otherwise, repaired ASD, there is no residual problem. Echo is okay. It can be managed like a routine case without much complication regarding the cardiac. So this is how we finish the ASD closure. Madam, now we'll have a question answer, or shall we go for other presentation?
In the view that you have to be for another meeting at 7, I suggest you go ahead with the next one, and maybe tomorrow we can take some question answers if it's convenient to you.
Yes, madam, that will be fine. So I will share my screen again. Sorry, I have disconnected it.
Meanwhile, the residents, may I request you all to put down some of the questions that you all have. Dr. Taylor has to attend a meeting at 7 o'clock. So we will continue with our question answers even for today's lecture tomorrow.
Sure, madam. So I will go ahead with the second subset, which is ventricular septal defects. And definition-wise, it is a defect which is present in interventricular connection. And usually it can be seen either in isolation or in associated or in accompanying with any other complex heart disease. This defect has been associated with chromosomal abnormalities like trisomy 13, 18, and trisomy 21. So sometimes it is usually associated, especially with Down syndrome also. So VSD is the most common acyanotic congenital heart disease, and it constituting up to almost 40% of CHD. The actual incidence of VSD will be even higher, maybe because we are not knowing it, because some of the VSD has been spontaneously closed just prior to birth or within first week of or second week of birth. There are accompanying anomalies in about half of these cases. So usually VSD in isolation, we are seeing if you there are a lot of associated problems with the VSDs also. And women are affected slightly higher incidence compared to the men. Coming to the embryology, this is there will be two heart tubes to start with, and then they merge together and become one heart tube in around 3 to 4 weeks of gestations, and then it will divide into almost 5 segments. This end of trunk, one end which is on superior side, which is called as arterial end, the lower end which is called as the venous end, and then it is divided into the compartment. Near the arterial end is truncus arteriosus, been called in the heart tube. Then there will be bulbus cordis. There will be primitive ventricle, primitive atrium, sinus venosus, and the venous end. And then this is the bulbus cordis is gradually divided into the two parts. The middle 1/3 is conus cording, will give rise to LV and RV outflow, and the proximal 1/3 is future trabeculated RV. I am discussing this because it will form the base of what we are going to discuss about the embryology of VSD, which is slightly difficult to understand. Because this the growth of this tube or heart tube is very fast compared to the growth of this pericardium, and that is why it started infolding itself. It started infolding because this growth is faster than the growth of pericardium, and that is why it started infolding in itself, and gradually the atrium will come to this part, and then ventricle will reach to this level like we are seeing in this part, and then gradually we kind of able to see what the heart is. This part of bulbar cordis which I mentioned is it's formed the RVOT and LVOT. This is the left ventricle side. This part of bulbus, the lower part of the bulbus cordis form the trabeculated right ventricle, and then gradually this atrium also goes and grows and goes in behind the things, and this will become the LA, and this part become RA. So now comes to the embryology of interventricular septum, which is slightly difficult to understand. That is why I form some of the basic point in the saying about the heart tube. I will read out first, and then we'll discuss how to make it much more simplified. In early embryological development, the muscular septum grows upward from the floor of the ventricle towards the already fused endocardial cushion. And this foramina is called as interventricular foramina. So this septum is start growing in this direction as well as start growing in this direction. Meanwhile, two spiral ridge from the conotruncal. This is truncus arteriosus, which we already discussed. And this part of a truncus arteriosus here there will be one septum which started growing, which is called as aortopulmonary septum, and gradually it will grow in a spiral way, and then it will divide this truncus arteriosus into two parts, aorta and pulmonary, but it will be growing in a spiral form, and then gradually it will grow towards this direction and fuses here, and then this part of interventricular foramen also been created. So IVS, interventricular foramen, is been formed by three different structure. One is this structure, which is muscular septum, the endocardial cushion, and the third one is which we called as conotruncal ridge, which is developing from the top end. So this how we make it much more simpler. The AV cushion it started fusing, and then gradually it formed here, and this part of membranous septum is formed by the AV cushion. The muscular septum, which I already discussed, start growing here and then growing in this direction, and then spiral septum, which I called as APS, start growing in this direction, which is dividing the aorta and pulmonary artery also, and growing in the direction. So all these three will form muscular septum. This is how this muscular septum, the interventricular septum forms. Membranous septum, this is called as membranous septum, this is called as muscular septum, and this is called as bulbar or conal septum. And any defect in all these things will come as one of the classification of VSDs. This is also another example of understanding is in this another view, which is called as interventricular foramen, which we already discussed. The AV cushions start growing in this direction. The septum, which is spirally going into this direction and fuses here, and the muscular septum will grow in this direction. So there are three dimensional structure in which the interventricular septum forms. And the part of interventricular septum is, this is inlet portion of interventricular septum. Second is muscular portion. This septal band and trabecular portion of interventricular septum. The fourth one is outlet part of interventricular septum. And the classification, anatomical classification of VSD also depend on this structure. So if it is finished defect in the muscular septum, it is called as muscular VSDs. Either it is anterior muscular VSDs, mid muscular VSDs, apical VSDs, posterior VSDs. Either sometime only one VSD will be there, or there will be multiple VSDs. If there are so many VSDs present in the muscular septum, sometimes it is called as Swiss cheese VSD. If defect is there in the inlet VSD, it is called as inlet VSD. A defect is caused, and if it is defect there in the membranous area, it is membranous VSD, or if it is enlarging towards the other part of the septum, it is called as perimembranous VSD. Or if VSD defect is there in outlet septum, it is called as outlet VSD or infundibular VSD. Or we'll have another slide which will describe individual VSDs also. The same figure is seen in this diagram also. So coming to one by one, which we have described, perimembranous VSD, the synonyms of perimembranous VSD is subaortic, infracrustal, or membranous VSD also can be called. The perimembranous area is a defect in the membranous septum of a VSD. Usually extends somewhat beyond the membranous septum in the adjacent area, and that is why it is called as perimembranous VSD, which already I mentioned. And then this is the most common in all kind of VSD, which is comprised of 70% of all VSDs. The other VSD which described is muscular VSDs. Either it is present in trabecular or apical VSDs, and muscular VSDs are trabeculated segment of muscular septum. And as I already mentioned, if there are multiple VSDs present in those area, it is labeled as Swiss cheese septum. And this kind of a septum sometime warrant to do pulmonary arterial bending rather than closing all the VSD, which is difficult in infancy or lower age group. With improvement of the diagnosis and the echocardiography and the expertise, now many of the VSDs is been diagnosed. But if they are very small, there are tendency to close spontaneously in first few week or months of a life. Infundibular VSD, also known as outlet VSD, subpulmonary VSD, doubly committed VSD, or subarterial VSD. And in infundibular VSD, there is a gap in the outlet septum. Usually, this is associated with a top kind of a VSD also, because it is outlet VSD. And many times it is associated with aortic valve prolapse because it is near to that. Even in a perimembranous VSD also, there will be chances of prolapsing of aortic valve and causing aortic regurgitation. Is one of the indication to close the VSD irrespective of age group of a child. This infundibular type of VSD is not very common, incidence by 5 to 8% in Western world, but in Asia it is higher, up to 30%. In inlet VSD, also known as AV canal type of VSD, or septum, it is associated with septum ostium primum ASD as well as inlet VSD, and usually associated with AV canal. So AV septal defect, if there will be large ostium primum VSD, large ostium, there will be large inlet VSD associated with either mitral or tricuspid component of valve is leaking. It comprises around 5 to 8% of all VSDs. The last, which is not very usual to diagnose or understand, but let's see. So there is a septum, which is there is a septum of either it is called the perimembranous septum or membranous septum, which divide not from the not LV and RV, but also it divides LV and RA. This part of a septum, because tricuspid valve is slightly downward placed compared to the mitral valve in normal anatomy, and this area between LV and RA, there is an interventricular septum. There, if there is a defect here, it is called as Garbody defects, and this is there will be very huge shunting, because LV pressure and RA pressure, there are huge difference, and that is why these patients present very early. This patient develop congestive heart failure very early, and that is why it is needed early surgery in such kind of patients. The classification wise, VSD also classify depending on the size of the VSD, and the size will be compared with the diameter of aortic root. If we consider small VSD, which is less than 50% of the diameter of aortic root, if the VSD is almost same size or 50% of aortic root, called as medium size of VSD, and if a defect is higher than diameter of aortic valve, it is called as large VSD. So there are two classifications we already seen: anatomical classification of VSD and depending on the size of the VSD. So we have seen anatomical classification, we have seen size of a VSD also. And the last classification, which is not very routine, is the cardiac, depending on the cardiac cath, and they calculate QPQS. If a QPQS is less than 1.4, it is called as small VSD. If a QPQS is 1.4 to 2.2, it is called as moderate size VSD. And QPQS is more than 2.2, it is called as large VSD. There are other type of classification which will some your level one not be need to remember is VSD related to the resistance. If it is restrictive, a small VSD, non-restrictive, it is called as large VSD. This is how we classify all VSDs in a different way. Regarding the natural history of VSDs, spontaneous closure happen in 30 to 40% of VSDs. A spontaneous closure is most often seen in trabecular or muscular VSDs. Spontaneous closure is much more frequently seen in smaller defect of or small VSDs rather than large VSDs. Spontaneous closure is more often seen in first year of life rather than later part of a life. So larger defects tend to become smaller, but they will not close. So if somebody is diagnosing a large VSD, one should not give hope to the relative that it will close. Or if a patient is present after first year of life and the VSD is not closed, one should not give a hope that this VSD will close. And as I mentioned, if it is not muscular VSD, it is not usually closed. So same thing, one should not hope to give hope to the relative that it will close, because it is fall in 30 to 40%. You have a chance of 1/3 to half of the VSD will close. Not all the VSD will close. So inlet and infundibular VSD mostly will not close. If a child will develop usually with the VSD, congestive heart failure develops after 4 to 6 weeks of or around 2 months of life, because gradually the PVR fall and then large VSD starts shunting hugely left to right, and then congestive heart failure sign and symptom will seen. Many of the time pulmonary vascular occlusive disease can be seen even in early life, around 6 to 12 months, in a case of very large VSD or in a case of Garbody defects. So one has to note that VSD do not become larger, but occasionally become smaller or close spontaneously. But infundibular, inlet or mild aligned VSD will not close spontaneously. So one has to be remember that. And sometimes we have seen in our practical experience also that there are a lot of muscular VSDs will be there, and surgeon operate and close only 1 or 2 VSDs. Later on, this smaller VSD, which is very small to start with, it start looking bigger. So it is possible that this sentence also may not be exactly correct. Pathophysiology, in a smaller VST or moderate size of VST, there will be volume overloaded of LA and LV and not RV. One has to remember this, that RV will receive volume of left to right shunt but act as a conduit, and that is why in a small and moderate VST, LA-LV will be enlarged, not right ventricle. But in the larger defect, RV also come under volume and pressure overload, and that causes RVH and RV dilatation also. Because there will be tremendous increase in pulmonary blood flow, and depending on the size of the VSD and the shunt flow, there will be changing in pulmonary vascular resistance. But if there is a large VST, there will be a severe PH. One has to remember this. If a cardiologist has mentioned there is a large VST, that means it is a severe PH. And this severe PH, if it is VSD has been not been treated, it will causes changing in the pulmonary vascular bed, and then later on it become pulmonary vascular obstructive disease, and then become irreversible shunt and causes right to left shunt, reversal of shunt, and again there will be Eisenmenger syndrome can happen in this kind of a patient also. As I mentioned, same thing, pathophysiology, because RV is just act as a conduit in a smaller and moderate side VSD, the blood from the LV shunt directly towards the pulmonary artery and increase volume overload LA and LV. That is why LA-LV will be dilated in small and medium size VSD. But in large VSD, there will be hypertrophy and dilatation of RV, PA, LA, and LV. Depending on the QPQS also, there will be we can diagnose the VST is large or not, and if it is 25% of shunt for the VST, the QPQS increase 1.3 fold. That means heart has to work 1.3 fold of a normal heart. If 50% of the shunt, which is left to right shunt, the heart has to work 2-fold. If a shunt is 75%, heart has to work 4-fold. And if 80% shunt across the VST, the heart has to work 5 times. And that is why, because of this, there will be development of congestive heart failure depending on the shunt flow or QPQS. The clinical features different to type of VSD, small and large. In a small VSD, because of flow towards flow from LV to RV, there will be left to right shunt, and then you will able to say holosystolic or pansystolic murmur heard in this. And because of not much flow going to the pulmonary directly pulmonary circuits, there will not be much murmur regarding the high pulmonary blood flow. But if it is large VST, there will be pansystolic murmur present in, or sometimes it is not related, because large VST will not give much murmur, but there will be murmur related to the high pulmonary blood flow. There will be loud P2, and there will be A2P2 split will be present. And in because of that, will be relative mitral stenosis, because there are a lot of blood going from the LA to the LV, which is received from the RV. Relative mitral stenosis will give rise to mid-diastolic rumble in the presence of large VST. So this is how the easy way of remembering a small VST, either pansystolic murmur or ejection systolic murmur, normal S2, systolic 3 present. But it is moderate to large VST, classic pansystolic murmur, mid-diastolic rumble because of relative mitral stenosis. S2 split will be narrow, P2 will be loud, and ejection click will be present. So this is what in the large VST. ECG and the VSD also depending on the size of a VSD. Small VSD, heart not much change, normal ECG. In moderate VSD, there will be LA-LV dilatation, LVH, LV volume overload will be, and left deviation will be there. Large VST, because LA-LV and RV also dilated on a hypertrophy, there will be biventricular hypertrophy, LA enlargement, and LVH and LV volume overload will be seen in ECG. Chest X-ray also, because of high pulmonary blood flow, there will be cardiomegaly, LV type of apex because LA-LV dilated, PH, and that is why it is called, there will be prominent PA, increased pulmonary vascular marking because of high pulmonary blood flow, and LA also is enlarged. This is typical X-ray of VST. And Eisenmenger patient, if it is there because of pulmonary vascular occlusive disease, there will be central cyanosis, no pansystolic murmur. H2 will be loud and single P2 and silent pericardium. Chest X-ray, there will be not cardiomegaly, prominent central PA and peripheral pruning, which we already discussed in the AST patient also. Management depend on the size of a defect, magnitude of a shunt, cardiac failure, location of a defect, and PA pressure. So size of a shunt is large VST. Obviously, they cannot be kept on medical management. They have to operate as early as possible. Like a Garbody defects, definitely one has to operate early. Like there is a severe LALV dilatation, severe PH is there, one should not wait. There will be recurrent hospital admissions. One has to operate this patient earliest. So same way, there are a lot of left to right shunt depending on the size of the VST. Larger VST has to operate as early as possible. If there is a cardiac failure present, one should not wait but to operate and give benefit of a child, which will gradually resolve all the symptoms and totally reversible. And location of the defect, as I mentioned, AV canal defect with associated with mitral regurgitation, Garbody defects, defect with mild to moderate aortic regurgitation. These are the defect has to be closed as early as possible. Severe PH patients should be given preference to close the surgical closure or some of the cases device closure. What one should look for the preoperative case of a VST is size of the VST, location of the defect, is there is a multiple defect or not, associated symptoms, magnitude of QPQ, so magnitude of pulmonary blood flow, presence of right ventricular hypertrophy, and changes in RV and PA, size of the left ventricle and hypertrophy and all these things, ventricular performance, and relation of great vessels and associated problems. When to operate such kind of patients? As I mentioned earlier, the diagnosis, if there is a sign and symptoms, associated problems, AR, Garbody defects, large defects, earlier the presentation, you can operate even within 6 to 9 months or before 6 months also. Depending on the lesion, we already discussed, depending on the location, these are the location where we have discussed that these are the defect will not close, better to operate and close surgically or device closure. Larger defect, one has to perform surgery and already discuss about symptoms. And some of the patients, if presented later part of life, cardiologist has to do a oximetry or a CAT study to see that pulmonary vascular resistance is reactive and can be operated. Madam, just a minute, I will receive one call.
Please.
These are the patients we have to operate, and it is not like that a smaller kid should not be operated. There are some norm of waiting till 10 kg, because this patient will have a heart failure and they will not able to gain weight because the heart, as I mentioned, QPQS is very high and heart has to work higher than what the normal is. And that is why this patient, because of they will not have energy to take a feed, they will not gain weight, and it will be a vicious cycle. So one should not wait that only 10 kg can be operated for the VST simple defects. It is not like that. Treatment option is, one is device closure, other is surgical closure, and there will be option if the surgeon is unable to close all the VSTs, or some of the cases PA band, some of the cases not to close and wait and watch. So regarding the anesthesia perspective, if a patient is coming for elective VST closure, we are taking, we usually put a peripheral line in all the cases in the ward, and that is why we give sedation in the recovery area and taking the patients. So we are giving ketamine and midazolam in the recovery area and taking the patients inside. But less than 6 months is not problem of if patient is not having IV line, one can directly take, because easy to separate from the parents and they will not kind of understand what is happening. So that is why not very difficult in a smaller kid to take directly inside the theater. Because it is left to right shunt, IV induction is better than inhalation induction also can be preferred rather than like cyanotic patient where we preferred IV induction. But we usually give balanced anesthesia, like we start with the sevoflurane also, and then we start inducing with a smaller dose of opioids as well as ketamine, midazolam, and then shorter acting muscle relaxant. Regarding pre-CPB management, because there is a large left to right shunt, and after intubation, one has to reduce the FiO2 as low as possible, because increasing the FiO2, you are further increasing the left to right shunt and further worsening the symptoms even before going cardiopulmonary bypass. So FiO2 has to be reduced as low as possible. The PaCO2 slightly keeping higher. So that is why we are keeping slightly lower respiratory rate to increase the PaCO2 to an extent of around 40 to 45 to reduce the left to right shunt. And then tidal volume has to be adequate. There has to be PEEP because there will be a lung congestion to start with. These are the pre-op ventilator management CPB. Perioperative, I think we are more than 5 kg. We are putting TE probe to perform pre-op TE also to see that there is not any other problem apart from VST. See the aortic wall as well as additional VST present or not. After coming of bypass, if definitely if we are having a epicardial or TE, one has to check there is a closure of properly VST and there is no LVOT, tricuspid regurgitation, mitral regurgitation. But another way of seeing that effectively close or not, one can do blood gas of step up can be seen. So a blood from RA and blood from PA. So if there is a defect in the VST or residual VST, there will be unexpected higher step up, higher saturation in PA gas, because RA blood, same blood going to the RV and same blood going to the pulmonary artery. But if there is a defect or residual defect present in the ventricle level, the oxygenated LV blood mixing with deoxygenated LV RV blood and increasing the saturation. So if step up is more than 6% between RA and PA blood, that suggests that there is a significant residual VST present, and one has to check with the echocardiography and again go for bypass and do the needful. Useful of PP, we are putting PA line in most of the smaller kit, but it depends on the unit to unit. And choice of inotrope, I usually start with the Milinon because we are closing the defect which is between LV to the RV, which is low resistance defects. After closing the VST, the LV exposed to the systemic vascular resistance, which is higher. So here also we have to keep lower SVR, and that is why Milinon is drug of choice. Even Milinon will help in reducing the PA pressure also. So, and in addition to Milinon, either dopamine or adrenaline can be started. Early back extubation, we follow on-table extubation in the bigger kit, but in ICU 4 to 6 hours extubation is safe. Fluid management post-operatively, one has to be kind of very judicious of giving extra volume, because already they will be congested lungs. So if needed, diuretics can be started, and I already mentioned about echocardiography. VST patient coming from non-cardiac surgery, if it is repaired case, then there will be residual, one has to look for residual VST, residual pH, other anomalies, saturation is normal or not, and RV-LV function. If all these things are negative, then this VST can be taken as a routine surgery. There will not be additional risk. But if there is a residual VST or residual PAH on saturation on the lower side, function is not okay, this will become high risk for non-cardiac surgery. In unrepaired case, it definitely goes for high risk group, because there will be PAH or there will be pulmonary hypertension. So one has to be careful. And then the person has to look for this is reactive PH or not. If it is reactive PH, the risk will be slightly lower. But if it is non-reactive PH, the risk will tremendously goes very high, and one can cancel elective cases if this is there and refer to the pediatric cardiologist for the management, optimize the pulmonary vasodilators, and then go for the non-cardiac surgery. PH, if it is there, then if it is mild, moderate, and severe, mild, moderate is still okay. Severe PH, one has to be very careful when giving anesthesia for non-cardiac surgery. Saturation, as mentioned, should be normal, or it has to be more than 93%. If it is less than 93%, it is termed as a clinical cyanosis, or and then one should look for that if there is a Eisenmenger rise or there is another problem why the saturation is low in left to right side. Age of the patients, unrepaired case, higher the age, the risk will be higher because development of pulmonary vascular occlusive disease is higher in this age group. RVLV dysfunction has to be seen on echocardiography in unrepeated case, and depending on the non-cardiac surgery, one can decide about which kind of anesthesia should be given. And very important is counseling and consenting about this kind of patient, which is very high risk going for non-cardiac surgery. So this is how we finish our ventricular septal defect cases. Thank you, madam.
Thank you, Dr. Tailor. I understand that you have another meeting, but I'll just ask our head of the coordinator, Dr. Alka Halbe, with us. Madam, would you like to say a few words?
Yeah, that was really excellent and very, very detailed. Like a student must have understood, because even I understood a lot of things, in this. So thank you, Kamlesh. You have done really great job. And including the non-cardiac surgery was a great thing. Actually, that is what student will be asked many times, more than a cardiac thing. Because see, in the exam, what happens if the examiner is doing cardiac cases, then the examiner will tend to ask cardiac thing. But if the examiner is not doing cardiac, they will tend to ask non-cardiac surgeries for this. So it was good you have included everything.
Thank you.
And it's really nice. Thank you.
Thank you, madam. Madam, I am preparing one topic on non-cardiac, pediatric cardiac patient for non-cardiac surgery. So maybe we'll have one presentation on this, and after 3 months maybe.
Yeah, so that will be really good. That will be really good.
Yes, madam.
Okay, so I think we'll relieve Dr. Tailor today because he has a meeting to go to, and we are meeting tomorrow sharp at 4. There were some questions in the chat box, and I've requested the residents to put up the questions tomorrow, and we can answer them tomorrow before we start our session. Yes?
Thank you, madam. Thank you,
Thank you so much for
thank
being
you.
with us. Thank you. And thank you all of you for joining us today evening. Thank you.
Thank you, madam.
Thank you.